All right, listeners, welcome back to the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I am a radiologist from Dallas, Texas.
And I am Alastair Moss, a cardiologist in the UK. We have had the opportunity over the past few podcasts to really dissect some of the challenges faced by our highly esteemed experts in the setting up and delivery of coronary CT in their hospital services. But what's it really like for people who are new to cardiac CT imaging? Well, for that perspective, we have the opportunity to gaze some words of wisdom from none other than the lead host of the podcast, Praveen. Praveen, as our listeners will be aware, is an attending cardiothoracic radiologist in Dallas, Texas. And Praveen completed his residency at the University of Texas Southwestern and went on to perform his cardiothoracic fellowship at Mass General. Praveen, you've got some extensive experience in doing cardiovascular imaging. I'm just wondering whether you could actually take us through your radiology journey so far.
Yeah, Alastair, thanks. It's a little strange for me on the side of the host to be discussing my own history, but I'm happy to join you in this conversation and discussion. With regards to my journey in radiology, I guess we can start at the beginning. I don't know if it was necessarily something I knew about when I was a child. I always had a fascination for science and human biology, but the reason why I joined radiology was mostly at a career day in medical school. I wanted to avoid a particular anatomy lab partner that was rather frustrating to have to deal with. And I sat down at the nearest table filled with residents, and it happened to be the radiology table. They then went on to discuss some of the interesting ways that one could marry physics and human biology together with providing patient care. And the journey sort of started from there. This was in New Jersey in the States. After that time, I joined residency at, as you had mentioned, at University of Texas Southwestern, where I fell under the tutelage of Sunny Ibarra. And from there, just got more and more involved in a variety of different cardiothoracic imaging projects. Prabhakar Raja was also a pretty significant mentor for me at that time, and we got involved in a multitude of different internal projects, grant-related projects, and other very fascinating things within the field of cardiothoracic imaging, which started to hone in more and more on cardiac CT. After that time, I joined Massachusetts General, where I joined the Cardiovascular Fellowship Program. Nina Meyerson was the fellowship director at the time, and the director of the division was Brian Gashadra. And at Massachusetts General, I took away quite a lot of lessons, primarily because it is a busy clinical practice. They do a tremendous amount of clinical cardiac imaging, notably clinical cardiac CT. And from there, I gained a reasonable amount of skill in how to optimize cardiac imaging workflows for clinical medicine. I used a lot of those skills and brought them with me into my early practice in Texas, where I am at present, where I joined a relatively large private practice in radiology here in Dallas. I was one of a few other cardiothoracic imagers, or those that were trained, dedicated in cardiothoracic imaging. And we built almost from the ground up a lot of different cardiothoracic components of practice and optimized many of the other cardiothoracic service lines that were already pre-existing with some of our clients. Some of the most valuable components of work, as I'm sure we'll get into in our conversation, has been developing those ground up programs, particularly in settings where we haven't had a lot of resource. So the journey in radiology has been quite detailed so far, but I'm hoping it's just starting.
And Praveen, you've been a member of the first committee for SCCT for a number of years. So you've clearly got a strong interest in training in cardiac imaging. I just want to go back to your time during the cardiothoracic fellowship that you were doing, both at Mass Gen and then also under Sunny's tutelage when you were down in Texas. What was it like working in those programs? What was your experience of actually being able to get hands-on with cardiac imaging for the first time?
Yeah, for sure. So starting in residency, at least in the United States, there really aren't a tremendous number of trainees that have interest in cardiothoracic imaging. Some of the more, we'll say, popular specialties in radiology are outside of the chest. So I happen to be really the first person in many years that expressed interest in the field. So I was outnumbered by all of the mentors that were there with me. And that naturally fostered a lot of different, really strong relationships with various mentors there, obviously Sunny and Prabhakar, of whom I mentioned in particular. And they got me involved not just in research projects and things like that, but as you had mentioned, Alastair, my membership in the first committee as part of the Society of Cardiovascular CT. And that's really what helped broaden my interest beyond just the walls of that hospital, that medical system, but rather into the other national and international institutions that were out there, made friends, including yourself, Alastair. And this podcast was born as a project of ours from the first committee. So that's been extremely valuable in terms of understanding perspectives from others in learning about cardiac imaging. At Massachusetts General itself, as I had mentioned, the practice is very high volume. Now, it's only been increasing since that time, but while I was there, on a typical coronary CT service day, we'd be performing anywhere from 30 to 50 exams in a day, which really helps solidify the ability to discriminate subtleties in disease. While it may not be extraordinarily difficult to interpret the ends of the spectrum in terms of any sort of cardiovascular disease phenomena, the really bad disease versus the normal disease, normal patients, the subtleties in patients that have intermediate level disease, in the example of coronary artery disease, intermediate level stenoses, is really difficult. And seeing such high amounts of volume and also being able to quality control myself relative to catheter angiography that was performed subsequently for those patients really, really helped in honing down my own personal ability to practice my craft better. Not only just within cardiac CT, there was a multitude of other great multidisciplinary practitioners that were present at the institution in cardiothoracic surgery, interventional cardiology, structural cardiology, and more. And having multidisciplinary meetings, conferences, and phone calls with all of these people really helped speak their language and bring some of their understanding of disease processes and how they talk about it into the reporting that I was doing. As an example, there would be weekly and monthly catheter angiography conferences in which it really isn't limited to catheter angiography alone. We would discuss nuclear imaging, coronary CT, cardiac MR, and catheter angiography, not just from the imager perspective, but from our preventive cardiologists, our heart failure colleagues, and our interventional cardiologists. So altogether, we're able to help refine our practice, and being part of that during fellowship was excellent. On top of that, we had the ability to transition between what I'll call the former way of practice in cardiac CT, the way in the places from which it originated, to what is likely the future of cardiac CT. The origins of cardiac CT, as many on the podcast before me have talked about, are turning the knobs and pushing the buttons at the scanner, honing each individual exam to be particularly tailored to a question that's being asked from our referents about a disease process. Now, that's quite boutique, bespoke medicine. However, the future of cardiac imaging is one of increasing volumes, one in which the same question is asked many, many, many times over. For that reason, it's very difficult to perform boutique and bespoke medicine for these types of questions, in this case, cardiac CT. While the buttonology and how to turn the knobs are important, one also needs to learn how to expand and homogenize practices to help deliver care to those patients that need it. And that was also something I felt like I was part of during my fellowship program. We sat and read next to the scanners, but not in the scanner room, because we had a tremendous number of exams to read from, and they were coming from many places. Not only did we get to do the buttonology and understand how to manipulate the hardware and software to get those high quality images, but we also had the ability to read from such a wide variety of institutions and therefore disease processes to help understand how to homogenize and expand a practice to accommodate for the flood of medical care that we are currently experiencing right now, you and me, Alastair. So yeah, I think those components of my fellowship and really training altogether have been very valuable for me.
Praveen, I love that idea of, obviously building volume and complexity to understand your own precision metrics on sensitivity and specificity as it relates to a particular feature like coronary obstructive disease. How did you develop that? Did you did you have a facility where quite a lot of the patients that you were seeing were going on to have another invasive assessment or a second downstream investigation? Because
Yeah,
obviously we're living in a world now where CT may potentially be the only test that's done for some patients, and it just may be difficult for future readers to be able to have that level of precision about how they can actually read.
exactly. And there's two components to developing, at least from my perspective, to developing that ability to discriminate the subtleties of disease. So one came from real life practice, and that is going to be beneficial for me in terms of the time in which I was learning and training. The time in which I was learning and training was one in which, yes, coronary CT was a well established modality, but it wasn't trusted 100% to exonerate all disease. For the purpose of coronary artery disease, when I was in training, we utilized the CADRAD system to help standardize the reporting, but it also helped standardize how we performed our own personal quality control. Many of these patients with obstructive disease or even potentially intermediate stenoses, a so-called CADRADS3, would end up going on to get some subsequent diagnostic testing, whether that be perfusion-based imaging, whether that be coronary angiography, catheter-based angiography, or something of the like. So I was able to collect those data for me personally for patients that were seen in our institution and track my own personal sensitivity and specificity for each of my, let's say, CADRAD scores or each of my calls in terms of stenosis. But as I'd mentioned, that came primarily because I could do that. There was not 100% trust in cardiac CT as an imaging modality. However, in the future, trainees will probably be in a position where coronary CT, as you mentioned, is hailed as the gold standard for evaluation of coronary stenoses. And in that case, we may not get any subsequent diagnostic evaluations. So the second part of what I was able to use for my own personal discriminatory control or quality control is standardized databases. So there exist tools online, particularly those that are part of either board training or educational resources from various societies, including SCCT, that have adjudication both from CT and from either catheter angiography, nuclear medicine, etc. So using those standardized databases that have adjudicated cases in concert with what I was seeing in training helped me discriminate and improve my sensitivity and specificity for various calls, particularly as we're kind of discussing in coronary artery disease.
I'm intrigued, Praveen. Now that you've laid those cards down on the table, we know that the sensitivity of CT is greater than 95% in a lot of the patients who are coming through our service, and specificity is probably slightly more modest at around about 50-60%. What are your numbers?
Oh no. Okay. Well, early in training, they were exactly as expected. I was way too sensitive, and my specificity, I'm somewhat embarrassed to admit, but I think it's very expected, was a single digit number. That's okay. Um, I was able to see that increase to very similar to what we're being seen in specificities reported at large centers like the one I had trained at Massachusetts General. I ended up being around, for intermediate stenoses, around the 60 to 70% range. Since that time, as I've collected data at my own practice, I've been still floating around the 75-ish percent range for specificity for calling a moderate stenosis, an intermediate stenosis in a coronary vessel. Now, mind you, we're obviously not cathing everyone downstream from that, so we're enriching the population of those that I'm able to even QC with only those that ended up going to the cath lab. But at least amongst those, that's sort of where I sit. I know that's not the best, but I think I've certainly improved from what I believe was 9% specificity when I first began.
It's all about progression, isn't it, Praveen? It's all about progression. So how did you find the transition from radiology training to delivering a cardiac CT service then?
Yeah, I think all trainees can appreciate this in that you feel as though you are overwhelmed always. And when I was a resident, I felt like I was overwhelmed just with learning the basics of anatomy and physiology and how they manifest in imaging. Then as a fellow, I was overwhelmed with how to deal with the large volume and quote unquote running a service, i.e., reading all of the exams that were presented to me in a particular day. But once you transition to your attending practice, one imagines, oh, you quote know everything, right? So this should all be easy. Far from it. I think the thing that has occupied the majority of my mental stamina and my therefore growth over the past years since completing training has been all of the intangible components of imaging outside of the interpretation of images themselves. What happens to a patient when they first arrive at the reference office and they travel through the healthcare system until they get their results from their practitioner about, say, for example, a cardiac CT? There are a tremendous number of steps that these patients go through outside of the cardiac CT alone. In fact, at many of the institutions I practice at, the cardiac CT is less than 20 total minutes of time for this patient. But there are many, many, many more hours that go into the patient's experience that we tend to interface with. We do have to interface with how the imaging orders are presented to our reference, how they interface with our backend information technology systems, how the data are collected from the scanner and sent to a variety of different software solutions, both PACS and post-processing systems. How do we interface as a practice with industry, with hospital providers, with other clients? How do our referents speak the language? Why is it that some interventionists practice one way and others a different way? Why is it that some interventionists use a certain language to describe coronary pathobiology, but others do not? So all of those components outside of just looking at pictures and creating a report have been the thing that really aren't taught all that well because it's hard to teach. You don't really get as much exposure to these things as a trainee because they're not necessarily the trainee's responsibility. One needs to gain that basic competence in image interpretation before tackling these next problems. And that's where I am at present. I'm in the stage of my career where I'm getting exposed to all of these non-interpretive issues in imaging and trying to find creative solutions specific to my own practice to implement.
And we've talked a lot on the podcast about building new services. I guess what you're describing here is building new relationships, and that's obviously one of the things that you have to do when you move up into the higher echelons of trying to piece all this big jigsaw puzzle together. Is that some of what you're trying to contextualize now?
Precisely, yeah. At present, building those relationships with our referents and even the patients that are themselves looking at the reports is of key importance if we're going to become better practitioners of imaging specifically or medicine in general. Perhaps born from a piece of advice that I got from Sunny Ibarra long, long ago now. He told me, as a resident, you may not understand all of the details and the specifics of advanced cardiovascular imaging and cardiovascular disease processes, but if this is your interest now, go and sit in the back of the structural cardiology meetings and observe. You will begin to form those relationships with each of your referents with time. So I did exactly that. I, as a resident, didn't really know what was going on with structural cardiology, but I still sat in the meetings. And as time went along, as Sunny had predicted, eventually you would be asked relatively straightforward questions that were part of imaging, and then they got more and more advanced as you got to learn more and more of the language that's spoken and the disease processes themselves. So now I've translated a lot of what I've learned from that time into developing these relationships with practitioners that I work with. Some you're going to be forced to interface with because they are already familiar with how cardiac imaging is performed. They are your main reference. They know how to answer a particular question based on imaging. They know what type of exam to do, and they know where it can be done. So these will be your high volume reference from the interventional cardiology clinic, your structural cardiologists that know that they have a full-fledged TAVR program off the ground and they need this particular type of exam done, or even our cardiac surgeons who are anticipating a CABG and know exactly which type of CT they want to perform to evaluate for ascending aortic calcifications in anticipation of cross-clamping the aorta. But There are many practitioners out there, particularly in communities where resources are limited, that may not have that familiarity with the potential advantages of cardiac CT in answering questions. Those are the individuals with whom it's very difficult to form those initial relationships, but they will be extraordinarily valuable as you're growing a service. There's a service line that we've built out in a smaller town that's east of Dallas where there aren't a tremendous number of either cardiovascular imaging services or just general healthcare resources. But there was interest in developing a coronary CT, an eventual cardiac CT program. There were cardiologists practicing there, but they did not have much familiarity with the potential advantages of cardiac CT. So the question then is how do you help make them aware of these types of things? How do you build that relationship to start with? Many practitioners operate either in practices that are part of larger healthcare institutions or individual practices that refer to larger tertiary care centers. And those were the two avenues I took in terms of helping build those conversations and thus relationships with our referring cardiologists. I went directly to some of the corporates, the C-suite members of the large healthcare institutions, and asked them who their cardiologists are in this area. And then after I got that information, I went directly in person to their offices just to discuss with them what I would like to build and determine what their needs are. Perhaps there's alignment between what I can provide in terms of my skill set and what they need for their patients. And there happen to be a few cardiologists that see a tremendous number of patients with all sorts of different cardiovascular disease phenomena, most notably really advanced cardiovascular coronary artery disease for a given age of patient. And they didn't have much in their arsenal other than a referral for SPECT imaging in a place about an hour and a half away where patients were not really keen on driving to. So that was the manner by which I was able to develop a relationship to help the patients that were seen by some of these cardiologists, and therefore justify building a service line in cardiac CT in that area.
And Praveen, you mentioned earlier that during your fellowship you'd be doing high volume with high complexity, and you'd almost had like uh, a large referral base for doing all of those complex reads. What does your cardiac CT service look like when you go into these new areas? Do you go back to being on the scanner and pushing the buttons, doing those supervised scans, or are there other ways that you can sort of set up new services that can take some of these more sophisticated approaches that have been developed at these larger centers?
Yeah, so great question. So perhaps we can use the microcosm of this small town, it's called Rockwall here in Texas, as an example of what we can do with modern day hardware and software, but with the same disease processes that have been affecting humankind for thousands of years. Uh, with regards to disease processes, coronary artery disease is still the number one reason for referral for many cardiac imaging programs across the country, including the other much more robust programs with which I work. For Rockwall, we started by saying that is the main disease process. The questions about this disease are what we're going to try to answer for our reference first. However, we can utilize some of the advanced scanner technology, software, and workflows that have been created over the last couple of years to help address some of the difficulties in the resource in this relatively low resource area of Texas. So while the question is the same, does this patient have coronary artery disease, and if so, how bad? What type of scanner can we put there to help optimize our ability to answer that question? And we had the luxury of having the budgeting to purchase and install a dual source scanner in this relatively small hospital that services this area. So that is huge advantage number one. Now, obviously, that's not the case everywhere in the country. Many other places will have to use hardware that may not be as advanced as some of our newer generation dual source scanners, but at least we at this institution were able to leverage that. A component of that leverage came from the idea that there were so many patients that could have received better care with this particular type of scanner that the marginal benefit that's gained is so great compared to the marginal cost of upgrading the scanner from a mid-tier to a top tier or newest generation scanner. This was conversations that we had to have with those making the financial decisions on the large institution or large healthcare system level. As part of those relationships that I was developing with these referring cardiologists, you also develop relationships with the financial officers that are part of these institutions, the ones that are really making decisions with regards to budgeting and therefore purchase of equipment for a lot of these hospital systems. So we were able to gain that advantage in that sense to put in a really high quality piece of equipment to optimize for the fact that we're not going to have some of the resources I'll talk about now. So I am a radiologist of only a few in my practice that can perform cardiac imaging. And we have to cover a multitude of other centers that are in the Dallas and Fort Worth area. We cannot personally sit at that scanner to perform these scans every day of the week or even one day of the week, which is how we started. For that reason, we needed to find a method by which we can perform unsupervised scans, meaning no radiologist or cardiologist is present in the scanner room. You then trust your technologists and nursing staff to have a very streamlined workflow to get patients in and out of the radiology department to get a high quality set of images. So, in the initial stages of building the program, on-site, in-person training of our technologists was key. We had a great piece of equipment, sure, but you need to have someone that really knows what they're doing behind the wheel of this Ferrari of a scanner. So training the technologists, which is a skill that I learned while in fellowship with all of the various so-called buttonology, and imparting that information onto my technologists was a key part of developing the workflow. On top of that, you got to have protocols that are imaging acquisition protocols that are put in place. A lot of imaging acquisition protocols tend to be really bespoke. You can modify them a lot based on the size of the patient, calcium score, whatever. For us, that we didn't have that choice. We can't have a physician's eyes look at these images while they're being performed. You need to almost foolproof the method by which they're acquired. So we did exactly that in terms of trying to minimize the number of steps and therefore buttons to press for each of our technologists. So not only could I teach a technologist how to do this, but now they can teach all of the subsequent technologists they hire to perform cardiac CT imaging. So as a quick example, the type of imaging that we perform for routine cardiac coronary CT at this institution is a high-pitch helical acquisition calcium score scan or a non-contrast cardiac CT, followed by a retrospectively ECG-gated systolic phase post-contrast coronary CTA. So the reasoning behind that is that the dose remains relatively low, and the scan acquisition is very robust to a variety of different heart rates. And because the population tends to be, we're from Texas, our BMIs tend to be a little bit meaning higher than those in the remainder of the country and definitely the remainder of the world, we need to have the ability for scans on patients with larger amounts of soft tissue. So optimizing the scanner to be able to capture pictures without having our technologists need to make on-the-fly decisions was a key part of building that workflow. Now, I'd mentioned a little bit about heart rate control and the fact that our acquisition protocols are pretty robust to relatively high heart rates. The intent was to minimize the amount of nursing involvement for these patients. Yes, we are administering vasoactive medications, nitroglycerin, but the hope is that we don't have to have active second-by-second nursing involvement with these coronary CT patients. We only have one or two nurses that are available in the entirety of the radiology and cath lab areas of this hospital. And so we have to share the services of this nursing staff with various other things that are happening. We can't have second-by-second administration of a variety of different medications while the scan is happening. So for this reason, rather than perform what's a much more routine worldwide with either nitro spray or sublingual nitro, we instead use transdermal nitroglycerin or nitrodur. The hope is that you achieve some degree of steady state with nitroglycerin, and you can just slap it on the patient and let them wait until they achieve that steady state before getting them scanned. There are data certainly to back up this idea, but it allows our nursing staff to run multiple patients simultaneously without as aggressive care so they can perform the other tasks that they have. Furthermore, beta blockade or just heart rate control in general is somewhat optional if you're able to create an image acquisition protocol that can accommodate for a lot of heart rates. So while at present we do use oral beta blockade, the hope in the future is that we don't need to. So I know that was a lengthy answer to your question, but at present we perform unsupervised scans, primarily coronary imaging, though that's increasing now to thrombus evaluations and valvular evaluations. And we currently run the scanner for 1 day per week with the anticipation of doing things 2 days per week. And we do about 10 scans per day. That 10 scans per day, funny enough, is not limited by the amount of slots that are available. In fact, we could do all of them in less than half of a morning, but rather related to the pre-op recovery beds that are available. That's where we have our patients when they're getting prepped and recovered before and after their scans. And we only have so many beds available to get patients done, therefore a cap on the number of exams that we can do per day. The hope at this particular institution is to build this practice to perform exams 5 days per week, 7 days per week, 24 hours per day, inpatient, ED, and outpatient. But this process takes time. So patience is another component of this that I have had to learn certainly the hard way because I'm not the most patient of people. But this part of practice building has certainly taught me that.
And we're certainly seeing that actually that tends to be the direction of travel for a lot of the scanning protocols that we're doing now, Praveen, with the newest generation of scanners. Quite a lot of centers globally are choosing to withdraw the use of heart rate control just because you can potentially get away without that. And it's all about getting the volume, isn't it? So many of our patients need access to this service, and anything you can do to improve access has got to be better than having it as a really highly specialized, restrictive scan that may only be able to be done in a few centers. This needs to be a widely available test if we wanted to have all of the benefit that we see from some of the randomized outcome trials that we're seeing.
Absolutely, Alistair. In fact, many institutions that are already performing and have been performing coronary CT for many years now that are in the Dallas area are so overwhelmed with the amount of requests that there are week to month long waits, some even as long as 3 months long, that these patients need to wait to have their diagnostic imaging performed. So any means by which we can optimize and maximize the amount of examinations we perform per unit time is going to benefit our patients.
Just some final thoughts, Praveen. I mean, what do you think are the three key points from sort of lessons learned that you've learned and that you've taken away from this type of this project where you've transitioned into delivering a cardiac CT service rather than just learning on the service?
Yeah, I guess the three key points, we'll start with everyone is part of the team. Every single person. Of course, the patient, of course, those interpreting the exams, but your technologist, your nursing staff, your staff that schedules the exam, your front desk staff, the CFO of the hospital, the CMO, the referents, every single person is part of the team to optimize the image quality and therefore patient care that you're providing. For that reason, you need to develop a relationship with every single person that is in that team in order to be a leader in the cardiac imaging community locally. This takes a lot of effort, I understand, but it's so critically important to develop those relationships, particularly those with individuals in that team that may not be physicians, because the perspective they provide is invaluable. It's not something that you're going to learn from textbooks or learn even in your residency and fellowship trainings. It's something that is learned from those that have the perspective, boots on the ground. Next, I would say that, and kind of alluding a bit to the patience component from before, diplomacy is an exercise in patience. There are many components of building practices that require risk-benefit calculations and potential sacrifices in order to get things done. That component of diplomacy requires time. You are not going to be the only person making decisions. There are many other people involved in this process, and you need to allow them time to process. I was not really comfortable with letting people take their time when I first got out of training because training's fast. training is really quick. I was only in fellowship for 1 year. Yes, I jam-packed a lot of information into that 1 year, but it's fast. Life does not really move that quickly. Life moves relatively slowly. I know there's jokes about Texas and the pace of life that we have here. Some of it may be true, but you gotta allow people to process information in order to achieve adequate diplomacy. And then lastly, and this refers a little bit to what I was talking about at the beginning of our conversation, Alastair, is you got to learn how to speak the language of your reference. Particularly for my colleagues that are in radiology, we in radiology often, and some of the stereotypes are rightfully so placed in that we sit in the dark room away from many people for long periods of time. That is often to our detriment in that we lose the conversations, the relationships with the people that are asking us questions to begin with. We got to get out there to the interdisciplinary meetings, to the conferences, whether they be national, international conferences, to any method by which you can interface with your referents to learn the language they speak. How do they refer to disease processes? What sort of patients are they seeing? How did their methods of practicing medicine differ from that that's available in the peer-reviewed literature? And therefore, how can you as an imager tailor your interpretation of imaging to what your referent and therefore their patients need? That's probably the most important piece of advice that was given to me and that I can hope to give unto other people, is that speaking the language of your reference is critical.
And Praveen, you've really been a global advocate for cardiac CT, not just in the work that you've been doing, but also through producing this podcast. As one of the founding members of the Donut of Destiny team, I just wonder whether you have any reflections on your experience of the podcast.
Yeah, first of all, Alastair, thank you, because it was born from your idea, your vision to have a form of education through the audio medium delivered through the SECT to beyond just its membership. Anyone interested in cardiac CT, I mean, that intro is not a joke. We really mean it. Anyone interested in this, and allow them to gain a little bit more information about this burgeoning field. That, to me, was super cool. And being part of that vision with you was phenomenal. So the ability from the first committee as part of SECT to join in a project like this was so valuable. Since that time, we have talked about numerous different advances in the field, trials that have come out. This podcast has changed the way in which I interpret science. Beforehand, yes, I can read the science, I can highlight different parts, potentially even apply it to my practice, yada yada. But when you dissect it for the audio medium, it's a completely different way of looking at the science. And it really helped me understand disease processes and patient care so much better. So for anyone out there that's interested in being part of either the podcast or just the cardiovascular imaging community in general, I encourage you so strongly to reach out to your local leadership or to the societies that are out there, SECT included, to just become a member. Most, if not all, are relatively cheap to free for young trainees. It is absolutely invaluable. The personal relationships and professional relationships that I built through this podcast and just through the society in general have been invaluable. So, Alastair, really, thank you. I appreciate it.
Praveen, it has been an absolute pleasure just to be able to spend this time just discussing, your thoughts and, where your journey's come to date. It's been really insightful, and I know that our listenership will have a lot to take away from this. This has been the Donut of Destiny. If you like what you hear, please do rate, review, and subscribe to the podcast. We have had a fantastic response from people to date, and we hope to keep this going with more episodes to come. This, again, is the Donut of Destiny. Cheers.